I'm joined now by Dr. Robert Klautz, who's a well-known cardiac surgeon and a good friend. Robert is from the Netherlands, and thanks for joining us. You're also on the program committee for this outstanding meeting. Congratulations.
Oh, thank you.
I mean, it really is unbelievable.
It's a great meeting. We have great surgeons. I think we have all the great surgeons in mitral valve disease here over in New York. It's been a very busy and tight meeting, but it's fantastic.
It has been a busy meeting. I'm going to come back to, we've had a busy week, and I'll come back to that in a second. Robert, where do we stand? What's new in heart failure and mitral regurgitation, how we approach it and how we treat it?
Well, ischemic mitral regurgitation or functional mitral regurgitation is still a puzzling problem in heart failure. What we've learned is that not all patients benefit from getting rid of their MR, but there are definite patients who do. They have heart failure, which is a ventricular disease, so we definitely have to address the ventricle itself, either a medication, ICD, CRT, so there are various treatment modalities we have to use. But some of these patients have a significant amount of MR, and they suffer from their MR, and we can treat them. We can treat them predictably. Mm-hmm. And it's very good for the ventricle. The ventricles actually come down, but it's not true for all patients.
So are we getting a better handle on which patient and which procedure we should do?
I believe so. I think, for instance, the patients with very large ventricles, advanced disease, getting rid of their MR is not enough to save the ventricle. They need a ventricular procedure, which can be a reconstruction of the ventricle or maybe any other procedure on the ventricle or even a transplantation or an assist device. Right. So we know that the patients who are too advanced in their ventricular problem, they don't benefit from getting rid of their mitral regurgitation. Now the other issue is that some of the patients that we do treat and still have a reasonable ventricle have a recurrence of their mitral regurgitation. But that's only true for 10, maybe 15% of the patients. And in those patients, a ring procedure, which we normally do in these kind of patients, is not enough, and we may have to add something else.
In the ischemic MR, which you certainly have done a lot of fascinating and good work in, is the state of art right now, if the ventricle's not too big and there are other factors, is the state of art now revascularization, cabbage, and a ring?
I think there are many papers that show that it's a benefit, and last year there was even a trial that showed there's a benefit in these patients to combine the cabbage surgery, the bypass surgery, with a mitral annuloplasty, an undersized ring, yes.
I'm going to go in a different direction. Are we going to reach a point where where we're going to have a percutaneous therapy for certain of these functional MR patients that is proven efficacy?
Well, that's very interesting because these are challenging patients. Some of these patients are not too difficult to operate. Some we even already operate because we do this bypass surgery. But if we go to these more advanced heart failure patients, they are difficult to operate. They have a tricky post-operative course, very sick patients, and they may benefit from a percutaneous or less invasive procedure. And there are basically two procedures coming. There's the MitraClip that's already on the market, available. We have to wait the longer and bigger trials, the longer follow-up, whether the success that it seems to have right now will sustain over time. We know from the surgical equivalent of this procedure that the immediate success is reasonable, but the long-term success is not so great if you don't have an annuloplasty with the clip procedure itself. But what's on the horizon are percutaneous ring procedures, and the first experience in men has been done. I heard this meeting, and so I think we'll hear from that the next year much more. It's very fascinating. That's coming.
So we may get to that point. I want to switch gears for a moment. What about the tricuspid valve? Certainly a lot of discussion about concomitant tricuspid repairs. I know you had a workshop on this. Where do we stand with knowing what to do and when to do with tricuspid repairs?
Well, we know that if patients have, when they were diagnosed with a mitral valve disease, they have a severe tricuspid regurgitation, there's no doubt you have to do something about it. The traditional thinking was if they have a moderate TR or even only very little TR, it will disappear when you have the left-sided fix, if you have a proper mitral valve repair or a replacement. In some patients, that's not true. They have a perfect left-sided repair that remains good over time, but still they develop late TR and right ventricular dilatation. And we don't know yet exactly which patients that are, but it seems to go in the direction that it's not the initial amount of TR that's so important during their mitral valve surgery or before mitral valve surgery, but it's the tricuspid angular dilatation that's a crucial problem. So if it seems that if they're dilated beyond a certain point, they won't shrink back again, even if the left side is repaired well, and they just stay very big and they may even become bigger. So maybe the elasticity of the heart is gone in those patients. And we don't know exact the details yet, but we definitely need a trial on this subject. But the evidence suggests that we need to treat dilatation more than regurgitation.
Interesting point. Final question. You outlined, and you've certainly, again, to be complimented along with your other committee chairmen, members, and David, obviously, for a fabulous meeting. You and I got to participate in an interesting meeting at the Mitral Valve Foundation at Mount Sinai, which was 35 surgeons.
Yeah.
Watching operations. You were there as an expert. Hugo was there as an expert. What are your thoughts about that as a way to educate surgeons?
Mitral valve repair has been proven to be an excellent treatment for mitral valve disease. The problem is that the amount of patients an average surgeon is confronted with mitral valve disease is very limited. So a surgeon sees only a couple patients a year, and if you have to go to this repair business, which takes a longer time to learn than a mitral valve replacement, we're coming into this educational issue. How do we train surgeons to do good repairs, not only good results in the OR, but long-standing, outstanding results? And that's where education is crucial. I've been involved in the European Master of Mitral Valve Repair. It's an educational program where we train surgeons, small groups of surgeons, live surgery, 2-3 day meetings, and they have been very successful. We've probably trained all the surgeons in Europe, not me personally myself, but I've been involved in the last few years. But most of the European surgeons have been going to this training, which is a result or a successing of the original Club Mitral from Carpentier. And I think that's been a very, very good educational tool. But in modern times, I think we need a little bit more. We can extend our experiences by filming what we do. We can publish that on the internet. We can have interactive sessions on the internet. So I think there are many new tools we could use in the future.
Well, listen, I've enjoyed being with you. It seems like we've been in New York for a couple of years, but it's only been a few days. But I've enjoyed being with you as always. Thanks for teaching us.
Thank you very much,
Robert.
Thank you very much.